Pandemic of COVID-19, people have been very careful outside their household due to the virus transmits. But let's not forget that there are other diseases that we can catch it through coughs, sneezes, or through close contact with someone who is infected. One of these diseases is a bacterial infection named diphtheria. Diphtheria is an acute bacterial disease caused by toxin-producing strain of Corneobacterium diphtheriae. The name of this disease is derived from a Greek diphtheria, meaning leather hide. A quick glimpse into the history of diphtheria. The disease was described in the 5th century BC by Hippocrates, and epidemics were described in the 6th century AD by Aetius. The bacterium was first observed in the diphtheritic membranes by Edwin Klebs in 1883 and cultivated by Friedrich Loeffler in 1884. Beginning in the early 19th, prophylaxis was attempted with a combination of toxins and antitoxins. Diphtheria toxoid was developed in early 1920s but was not widely used until the early 1930s.
So in this section, we'll be talking about diphtheria or diphtheria, and specifically etiology of diphtheria. Diphtheria is an acute bacterial disease caused by toxin-producing strains of Corneobacterium diphtheriae, meaning it is Corneobacterium diphtheriae that causes diphtheria infection. Diphtheria is a serious infection caused by strains of bacteria called Corneobacterium diphtheriae that makes a toxin, a poisonous toxin at that. It is this toxin that causes people to get very sick. It is said people of younger age are more predisposed to this very infection, especially those below the age of 15 years. Though since the introduction of vaccine, the spread, the infection has really gone down. Diphtheria, as I said earlier, is caused by Corneobacterium. Diphtheria, as I said earlier, is caused by Corneobacterium diphtheriae, a slender gram-positive rod with clogged ends that spread from person to person in respiratory droplet or skin exudate. Basically, it means the spread is more of airborne, through airborne droplets or via skin lesion or respiratory secretion. And the infection may lead to respiratory cutaneous disease state or asymptomatic carrier state. Respiratory diphtheria causes pharyngeal or less often nasal or laryngeal infection. Damage to the heart, nerves, and other organs may be present as well. Cutaneous diphtheria causes chronic ulcer with a dirty gray membrane, but does not cause systemic damage. As I said earlier, the diphtheria is basically caused by Corneobacterium diphtheriae, a gram-positive bacteria. This Corneobacterium diphtheriae is a phleomorphic, clove-shaped, gram-positive bacillus that is catalyst positive, non-motile, non-spore-forming, and non-acid fast. It is an aerobic gram-positive bacillus. Toxin production occurs when this bacillus is infected by Corneobacteriophages carrying tox gene. 4 biotypes of it are Graphis, Intermedius, Metis, and Belfanti. All isolates are advised to be tested for toxigenicity. More elaborately, Corynebacterium diphtheriae is an aerobic gram-positive bacillus. Toxin production, that is, toxigenicity, occurs only when the bacillus itself infected or is itself infected by specific viruses, that is, corynebacteriophages, carrying the genetic information for the toxin, referred to as toxin. Diphtheria toxin causes the local and systemic manifestation of diphtheria. Basic types of C. diphtheria, as I mentioned earlier, are Graphis, Intermedius, Metis, and Delphanti. All these biotypes can become toxigenic and are capable of causing severe disease. Lastly, all isolates of C. diphtheria are advised to be tested for toxigenicity. That is that about this section and about short etiology of diphtheria. As we said, is basically caused by a bacterium referred to as Corynebacterium diphtheriae. Thank you.
Hi everyone, I am Donna Donig and I'm here to talk about the pathophysiology of diphtheria. By definition, diphtheria is an acute communicable disease caused by Corynebacterium diphtheriae. The disease is generally characterized by local growth of the bacterium in pharynx with pseudomembrane formation, or less commonly in the stomach or in lungs. Human carriers are the main reservoir. So if we say reservoir, it means that the source or where was it coming from. In regards to the pathogenesis of this disease, Corynebacterium diphtheriae have this mode of transmission that spreads via droplet contamination while chatting, sneezing, and coughing. Once infected, a person continues to be infected for 2 up to 4 weeks or until virulent bacilli are found in lesions. The quickly progressing febrile condition known as diphtheria has both local and systemic pathology.
Good morning, my name is Richard John Quizon, and I'm going to talk about the clinical manifestation of diphtheria. So, uh, the signs and symptoms begins around 2 to 5 days after infection, and the onset of symptoms is typically gradual, meaning um, there are small changes or development as time goes on instead of a sudden change. Now, absorption and dissemination of diphtheria toxin can lead to toxin damage of the heart, nervous system, and kidneys. Now, in the heart, it can cause myocarditis, and in the nervous system, it can cause peripheral neuritis and paralysis. And in kidneys, it can affect its ability to filter wastes from the blood. Now, there are two types of diphtheria, respiratory and cutaneous. And let's talk about the respiratory first. Now, diphtheria toxin induces the formation of coalescing pseudomembrane, and this membrane adheres tightly to the underlying tissue and bleeds with scraping, and this appears as a thick gray membrane. Now, this pseudomembrane can extend to any portion of the respiratory tract, from nasal passages to the tracheobronchial tree, and this can cause blockage to the airways, which makes it dangerous. Now, the involvement of cervical lymph nodes may also cause profound swelling of the neck, which is called bull neck diphtheria. Now, and the symptoms of this is fever, nasal discharge, weakness, sore throat, hoarseness, difficulty in breathing and swallowing, and of course, the swollen neck. This is an image of the respiratory diphtheria. Now, this is the gray patch. This is the gray patch-like membrane in the tonsil, and it can extend to further to the respiratory tract. And in the in this And in this picture, you can see the swollen lymph nodes, or what we call the bull neck diphtheria. And next is the cutaneous diphtheria. Now, the hands, feet, and legs are the most common sites involved, and this appears as an ulcer in the skin. Now, it starts off as a mild erythema or a rashes to the skin, and it will turn into a vesicle or fistule, which quickly breaks down and form a well-defined superficial ulcer with an overhanging edge. Now, it has an volcano-like appearance, and as the ulcer deepens, it will form a brown to gray pseudomembrane in the base, and the surrounding skin is pink to purple in color, and it can be swollen with a rolled appearance and possible blisters. Now, the ulcer is initially painful, and it will become asymptomatic with time. Now, infected skin can be a reservoir for respiratory diphtheria in others, particularly in areas with low herd immunity due to unsanitized areas. Here's an image of the cutaneous diphtheria. As you can see a grave pseudomembrane in the base, and the surrounding skin is a swollen and red color and it is in red to purple-like color. That's all. Thank you.
I will be talking about the histologic examination of diphtheria. So generally, a histological examination is not done routinely when there is already a likelihood of diphtheria infection. Histology is useful when diagnosing this disease when there is a co-infection with other pseudomembrane-forming bacteria like Staphylococcus and Streptococcus species. The first stage that is first affected by the disease is when there is a manifestation of edema and hyperemia of the affected epithelial surface. This area will eventually form necrosis and a release of a fibrinous suppurative exudate. This exudate will then lead to coagulation that will be the cause of the appearance of the next characteristic, which is the sturdy grayish whitish colored pseudomembrane appearance over the affected epithelial surface. The pseudomembrane will be primarily composed of the C. diphtheria bacteria and as well as a fibrin and epithelial cells that has undergone necrosis. While the membrane will be composed mostly of fibrin, which would be over the vocal cords, and the bronchus will be primarily composed of fibrin and neutrophils. If the muscular layer of the heart are affected, there will be a manifestation of an extensive hyaline degeneration that will be accompanied by the infiltration in the interstitium of the mononuclear cells and can show areas of necrosis and inflammation. The diphtheria toxins, or DT, can be observed under a fluorescent stain with the anti-diphtheria toxin or anti-DT antibody in the sections of the tissue within the myocardial fibers. Changes within the myofibers, which includes the degradation of the matrix, the enlargement of the mitochondria with excessive lipids, and the disorganization of the cristae can be observed under an electron microscope. With the injury in the histological examination, the infection has been observed to cause early changes in the myelin. This means that there is the increased width of the reindeer nose and other configurations structurally. There is also a very rare characteristic that results because of the disease, and this characteristic manifests itself as a lesion which is called segmental demyelination, which occurs when the disease progresses. And in some severe cases, there will be degeneration of the axons that can be observed under the microscope. That is all. Thank you.
Endothelial activation and injury. Sepsis affects the various aspects of the endothelial cell function and is said to be the key regulator in the progression from sepsis to organ failure. Now, the endothelial endothelial cell lining coats the inside of the blood vessels and configures the blood that circulates and the parenchymal cells that are responsible for the organs to efficiently function. Also, the endothelium forms the essential vascular barrier for solute transport and osmotic balance. As sepsis becomes associated with severe endothelial cell dysfunction, it leads to the dysregulation of hemostasis, vascular reactivity, and the tissue edema. A healthy vascular endothelium protects against excessive or abnormal inflammation and coagulation. When sepsis occurs, the body overworks itself from fighting the infection, which causes harm to the tissues as collateral damage. As a result, vessels can become leaky and the major organs cannot accumulate enough oxygen and nutrients. So endothelial cell activation associated with sepsis lead to the widespread of vascular leakage and tissue edema, which have deleterious effects on both nutrient delivery and waste removal. One effect of inflammatory cytokines is to loosen endothelial cell tight junctions, making the vessels leaky and results in the accumulation of protein-rich edema fluid throughout the body. So damage to the vascular endothelium causes edema and the collection of neutrophils and macrophages. This alteration or this change impedes tissue perfusion and may be exacerbated by attempts to support the patient with intravenous fluids. As the endothelium activates, it is regulated or it regulates the production of nitric oxide and other vasoactive inflammatory mediators such as C3, C5a, and the platelet activating factor or PAF. This may contribute to vascular smooth muscle relaxation and systemic hypotension. Microcirculatory changes in sepsis. Another feature of sepsis is microvascular dysfunction. Microcirculatory dysfunction is characterized by the increased number of capillaries with stopped flow and maldistribution of microvascular blood flow. Now, this is the major site of blood oxygen release to tissues and works as an integrated system that ensures tissue oxygen delivery to meet cell oxygen demands. Nitric oxide dysregulation and impairment of multiple cell types found in the microcirculation are involved in the development of microvascular abnormalities. So as you can see, it is shown here in the picture. Increased endothelial permeability results to fluid leakage from the intravascular space and tissue edema. The accumulation of water is a result of tissue hypoxia due to the increased diffusion distances between functional capillaries and tissue cells, which is combined with poor oxygen solubility and transport in tissue water. So there is an increase in capillaries with intermittent flow and heterogeneity of flow in various capillary beds, and the normal autoregulation of flow based on tissue metabolic environment is lost. So these changes cause a mismatch in oxygen and needs the efficient oxygen delivery or the required oxygen for the body.